morning, everyone, and welcome to Department of Medicine Grand Rounds. Today, it is my distinct pleasure and honor to introduce our speaker, who all of you know, Dr. Kim Williams, our Chair of Medicine. And Dr. Williams is known fondly across the world as a vegan cardiologist, a field he's very passionate about and may actually be the inaugural father of this field. And I think I heard once that if you Google top 5 cardiologists or top 3 cardiologists in the world, Dr. Williams comes up prominently because of his groundbreaking work in this area and other areas, including advocacy, as well as equity in cardiovascular healthcare. So I think it's very fitting that Dr. Williams is actually today going to talk to us about disparities in cardiovascular healthcare, and he's actually going to do it in a very innovative way, where he's going to give his thoughts in a presentation and then open up the floor for crowdsourcing and questions so that all of us can participate. It's going to be very interactive, and so I encourage you to think of thoughts and ideas as we go through this to solve this issue. Dr. Williams is a much sought after speaker, brilliant academician and clinician, and I've known him now for almost 2 decades. Really a remarkable gentleman. And so just to give you a brief background, he completed his medical school at the University of Chicago, and that was followed by a residency in medicine at Emory in Atlanta and a cardiology fellowship at the University of Chicago. He has served in many leadership roles. I'll just give you the highlights here, because otherwise I'll be here for half an hour if I talk about all of them. He's the past president of the American College of Cardiology in 2015, and a founding member and president of MASNC, which is the American Society of Nuclear Cardiology. And he's made so many seminal contributions in the field of nuclear cardiac imaging. Prior to moving here, was the James Herrick Professor and Chief of Cardiology at Rush in Chicago. So he was my boss there, and I got to know him very well as a mentor and a very good friend, and just an absolutely delightful person. He's also served as Associate Dean for Faculty DEI at Rush. He's a prolific author with over 400 papers, multiple book chapters, and he currently serves as the editor-in-chief of the International Journal of Disease Reversal and Prevention. So with that, Dr. Williams, the floor is yours. Welcome.
Thank you so much, Dr. Kalra. I really appreciate the opportunity to speak again. I'm hoping that Jason will come up with a Louisville Slugger bat for me this time. But that is by way of saying that I did give a lot of these principles when I spoke last fall. There are some updated data and some updated progress here at UofL that I'd like to discuss today. But the main purpose is to try and get everyone to just think deeply about the issues that we have, and with health equity in general, and our underserved population in particular, and to think programmatically about the ways that we as a university and as a medical center can really impact that. And so I'm going to share the screen, of course, and I'm going to actually start off with a bit of a quiz. All right. And so hopefully people can unmute. Jason promises me that if you unmute and not too much noise in your background, that this will go well. All right. And let's give it a shot. Okay. So achieving health equity in cardiovascular disease, hopefully we will keep this very interactive. And I'm actually going to start with an unknown. I have to admit that a lot of the principles in this talk I got from listening to our own division chief in infectious disease, Forrest Arnold, from his grand rounds a little bit ago. And so anybody?
Smallpox.
Is this? Smallpox, absolutely. Okay. And there it is. Beautiful virus, not so beautiful. So why is this cardiologist talking about smallpox? Well, I'm actually going to just highlight the fact that one of the founders of this country's really history. Ben Franklin published a lot about this particular issue. A solution had come up for this particular disease. He was rejecting it. He lost his son to the disease, and he changed his mind completely. And then he started really, pushing the data and getting people to understand that this was a disease that could be helped. Now, the interesting, where did he get the idea that they could be fixed? And why would there such racial disparities? Well, this is particularly a disease that was affecting people who were in close proximity to one another and didn't have a way to distance themselves from each other. And if you looked at the black-white differences in every outbreak, they were actually huge in terms of the number of people who died. Now, the interesting part about it is that the solution actually came from West Africa. It was a slave brought to the United States. It was in the Boston area during one of the horrific outbreaks where many people were dying, but Black more than white, again, because of close proximity to each other. And what he understood is that you could actually take the pus of one of the smallpox lesions and inject it into a person, and they could get the disease and die. But more than likely, they would actually become immune if you did it exactly right. And this was hard in the 18th century to get it right, but many, many lives were saved by an African slave, essentially. And when you looked at the epidemiology of it over time, every outbreak was a little bit less. As this therapy became more popular. Okay. All right, fans of history. Question number 2. What is this? Anyone?
Suez Canal. I'm
Close.
sorry. Yeah. The other one. Panama.
That's right. Well, and it's interesting that you said the Suez Canal, because the whole idea of being able to connect portions of the world, which was so important for commerce and trade, and the Suez Canal was actually a very important one. And people thought, well, we did it at the Suez Canal, we could do it in Panama. Who were those people? Mostly the French. And they really went after it, trying to do everything they could to connect Atlantic and Pacific. And things from China could go to Europe, and you wouldn't have to go around the Cape, around the southern tip of South America. And they went after it. Now, you have to understand that this was the late 1800s and had been slavery had been outlawed in the United States, and as you know, in the Emancipation Proclamation in 1863, and there were people who were freed a little earlier than that in the Caribbean, and people were really struggling to try to figure out how to feed their families. And so the French coming in with this whole initiative, allowing people to work for a living and send money back to where they came from. And what you see is they were really working hard, trying to clear all of this material to connect these two, just moving earth. And every picture I'm showing you, you see a lot of Blacks, okay? And so when the issues started happening with yellow fever, it had a horrific death toll that was Black-white, and it wasn't just close proximity, it was just the population that was actually doing the work. And it was such a blight on what was going on with the operations that the French pulled out. In the mid-1890s, they decided this is not worth the human capital that's being paid predominantly by Blacks. So as a humanitarian effort, they just quit. So it turns out that the particular problem, which was a mosquito, and that mosquito was sending out the yellow fever virus. There had been some experience with that during the Spanish-American War. It said that yellow fever and a few other infectious diseases, dengue fever, actually took more lives in the Spanish-American War than the war itself. And so folks at Walter Reed had really tried to eradicate yellow fever. They figured out that it was the mosquito and started mosquito abatement. Get rid of all the standing water, put oil on top of the water, oil floats, the mosquito can't breed. And everything they did allowed them to go back to Panama and start to dig an area with water and trenches and still survive it. And it actually worked pretty well. Again, a huge black-white difference that was cured by getting to the root of the disease. So this one, everyone, doesn't have to be a quiz. Everybody knows who this is, FDR, and knows that he had polio, and that polio virus, again, people who were in close proximity of one another allowed this to spread. And so there were not just black-white differences in the incidence of the disease, but there were also problems with the politics of therapy that were just unconscionable. You had very few facilities for the African-American population who had a greater burden of the disease. And there wasn't a lot of sense of racial equality to try to help the African-American community with it. So whatever happened to it? Well, it was the development of the vaccines. And by 1964, you had 3 different vaccines, and you could actually take this and send this disease into oblivion. So let's move to, so we did the 18th century, 19th century, 20th century, and now the 21st century. And you've all seen this before. And I know some of you may not have been at my last talk where we elucidated a lot of these principles, but people of color dying, it was recognized very early on with coronavirus. And what everyone thought is that it's something about us, you know, people of color that makes us die. And it was a lot of places, but the first one to go to publication was Ebony Price Haywood in New England Journal of Medicine saying, no, yeah, there's a lot of people who are dying, and a lot of them are Black. But if you do the statistical analysis, it's not their Blackness, it's not their race, it's their risk. And it's socio-demographics and its clinical characteristics such as obesity and hypertension, underlying heart disease, that actually makes people die from coronavirus. And so I talked last time then about what is it that we could be doing to try to follow those 4 centuries of changes. That is, you know, once we had the coronavirus, we figured out what the therapies were, we figured out what how the virus was going to respond in people who have been vaccinated. We could suppress this disease, it's not gone, but the huge black-white disparities that we saw before, they've largely been eliminated. We have more difficulty with older people than younger, and that's the current disparity. And so what is it that we're able to do in 4 different centuries with 4 different viral diseases? And the answer is basically to come up with solutions. And so what I talked about last time is the difference between equality and equity. Not sure that I mentioned the whole idea of reality, that in some societies, including ours, those who have end up with more and those who don't end up with less, but really putting forward the idea that we could do better. And that's what this session is all about. That is, how do we remove the fence so that we don't have the barrier in the first place? How can we address the existing issues, particularly in our healthcare system, particularly in cardiovascular disease? What kind of programs can we come up with that will try to impact this, that we can then be this sort of the shining star university and city and state, for that matter, that other people can try to follow. I never got to meet Dr. Benapati, but I can say that seeing her push to make University of Louisville the anti-racist place is one of the things that attracted me to take this position. And I really would like to do everything that we can as a department to live up to that, because it's very true that we may not be able to solve all of the issues of inequality and injustice, but if we can just start with healthcare, we can actually make a huge impact that other generations will continue to follow. So, I just want to throw this out here for folks to just thinking about the kinds of solutions that we could come up with. And I'm going to come back to this slide toward the end of the talk, just as sort of a way of categorizing the kinds of things that I'm hoping that we're all thinking about. I don't want to say that this is just cardiovascular disease, because that wouldn't be fair to a Department of Medicine that's dealing with a lot of issues, and whether endocrine, pulmonary, diabetes, obesity, which do relate to cardiovascular disease. And just note that, we have people of color in this country have far worse outcomes, and regardless of the disease that we're looking at. 2 weeks ago, at the American College of Cardiology, there was actually a health equity summit. And for those of you who are interested in this, particularly in cardiology, I suggest that you go online and pull up these keywords, or pull up the slide set. I won't spend too much time going through it. It's just, they had 50 people in a room talking about what is the definition of health equity, trying to get rid of the unfairness and avoidable things that are fixable, the differences in our health population based on a variety of things, not just race, but economics, which is a huge thing here in Kentucky. And I say that because we do know that it's not just the West End that struggles with health equity here in Kentucky. We would like to see these health inequities not be systemic. We'd like to see the disparities really improve, and that's going to require that we step back and look at ourselves as a society, but also that nothing is really meaningful unless we actually do something about it. And so recognizing the problem but not addressing it is really what we're hoping to not be our legacy. And so coming up with programs for health equity and to improve social determinants of health is actually what we'd like to do. So the ACC is hoping that these three pillars will pervade cardiovascular space and spread it to others. That's creating a culture of health equity and prioritizing health equity in everything that they do, and eliminating disparities by ensuring equitable cardiovascular care. That's going to take a lot of education and a lot of effort to try and change the way things are done. A lot of which I'm going to go through. Very, very briefly, just to remind you that we are still in the middle of a horrific pandemic with all the viruses I showed you. Cardiovascular disease has still been the leading cause of death in the United States, and that lower bullet, the 21% higher mortality in African Americans, which is exceeded by Appalachia, where it's 33% higher mortality rate. And so it's not just race. In this case, it's socioeconomics as well. But these are differences that we can address as healthcare systems. And yes, we have had a dramatic improvement in cardiovascular mortality for some races more than others. But because of our current dynamic, it's important to recognize that that decrease in cardiovascular mortality has essentially stopped. And if you look at Eastern Kentucky, the numbers are actually very striking. Premature cardiovascular mortality, and which parallels all-cause mortality, but cardiovascular remains number one. It's doctor shortages over there, and in the West End, it's access to care. I mean, we know that we are over there. I have a clinic on the West End. Norton is building a hospital there. Folks are thinking about ways of trying to improve this, and we'll have to do similar kinds of things all over the state and all over the country. But the main issue is that we need ways to improve the stressful, unhealthy lifestyle, improve education, and those, once we improve the education, the change in the poverty level will follow. So there's a wonderful article that I mentioned last time that was a nice outline talking about the kinds of things that would give us ideas and things that where we could work with, and trying to get racial justice and getting rid of gender disparities and working on poverty. Those are going to work. But one of the major things that we can do as a medical center is to work really assiduously on healthcare access. We have an opportunity, we have the attitude, we have the capacity to try to reach populations who are minoritized and are vulnerable. And the question is, can we really deal with the access issue? These were my thoughts that I may have, I think I did talk about this last time, but I want to know that, you know, when people say access to care, they're usually talking about, do you have appointments? Do you have doctors? I think it's much more than that. Yes, we do have issues of longer wait times, fewer providers, less diagnostic tests that I'll mention momentarily, and less subspecialty care for our minoritized populations. But it's not just that. We actually have access to poorer care, a very sensitive issue in that, and we don't talk about it necessarily as much as we should, but we are doing a lot of quality metrics in the Department of Medicine, but not every organization is doing those sorts of things. We try to have leadership that, you know, puts on educational courses, and we talk about guidelines, but we end up with out in the community, there's sometimes poorer providers. I can tell you for certain on the south side of Chicago that the people who were practicing in my neighborhood were not the same quality that they were on the North Shore or in the Magnificent Mile. And that led directly to that 30.1 year life expectancy difference between what they call Streeterville, which is up by Northwestern and Magnificent Mile, versus the inner city south side of Chicago, Inglewood neighborhood. And so if the providers are not adhering to guideline-driven management, the people suffer. But then lastly, it's accessing care poorly. And you never want to blame the victim, but sometimes, you know, we have to do a better job of educating our poor population who might be getting good advice, but poorly adhere to that advice. And the famous, the one that's been quantitated probably the most here is African-American men not paying attention to the advice given by providers who are not African-American men. That's really on us. We have to fix our understanding, our ability to relate to people in the community, and improve their lifestyle choices, but also get them to adhere to the understanding that we have about how to make their healthcare better. So I do want to talk about, I mentioned this one before, it's something that we haven't solved yet here at UofL, trying to get the socioeconomics of coronary calcium. It's tough to be in the clinic, have in Parkland, and have a patient who needs this test and not have a way to get it to them. The barriers were usually financial. Now it's actually more about corporate compliance. They're worried about, UofL Health is actually worried about us having philanthropy to give away a $100 test. Yet, you know, when I'm downtown and someone comes in and they have a job, me telling them that they need this test, and it's going to cost $100, it's not a problem. But for our West End population, this could be a problem. What we published on this is that, you know, and hopefully everyone has seen this, that coronary artery calcium is now a tried and true way of risk stratifying people. If you were in EPIC in the outpatient and you put in .ASCVD risk, you will be able to put in the person's lipids and blood pressure and their demographics and disease states and come up with what their risk is. And if they're between 5 and 20%, the coronary artery, that is a 10-year risk of heart attack, stroke, and death, that can actually lead to a coronary artery calcium score, which it's really important to understand that we don't have good data if you're in that range, that moderate range, and you have a 0 coronary calcium. We are not actually giving people statins. We're certainly not giving them antiplatelet therapy. But if they're more than 20%, then it's not going to be as helpful because that person may have some non-calcified plaque. But ultimately, if we're in that lower zone, 5 to 7.5, to sort of just below the moderate risk, and a person has one of so many risk enhancing factors, chronic kidney disease is one, but it's having an elevated LP little a, or having a family history of premature coronary disease. Any of those factors, high sensitivity C-reactive protein, for example, if those are present, then we lump them in with the people who are at moderate risk, and the coronary calcium can be helpful there. So very powerful test. And what we've found, unfortunately, is that if you're in a poor neighborhood, as shown on this slide, you're someplace with high poverty rate, low household income, lower education, then the hospitals near you don't actually offer the test. And we have to solve that here at U of L, not because of availability, but because of issues of the finances. We continue to have educational issues. Health literacy is a huge thing. And so I'm hoping that we can come up with creative solutions to try and just upregulate. There have to be ways of getting to people. Yes, we're going into churches and we're talking about cardiovascular health, but we need to try to do that as a department, as physicians, to try to interact with people, to get them to understand the pathophysiology behind their disease and in ways that they can understand, and to try to really get them to adopt more healthy lifestyles and adherence to medication. And that really is driven by health literacy. And so improving biases, they're always there. And this is something that we all have to try and step back, do our intrinsic bias training, and try to understand where we are as providers so that we can relate to our patients. That implicit bias is a shocking kind of thing that it's difficult to go through and realize that we are all biased in some way, and that it can actually affect our diagnostic skills and the number of tests that people do. And it can have a very famous outcomes, like, not believing Serena Williams when she had a PE before that she had a DVT. You can make television shows about it. Not everybody's going to see that. And we, at this point, I would think it's time to go back and repeat that Schulman experiment that was published 25 years ago, with the 8 actors all saying exactly the same thing for unstable angina, needing to go to the cath lab, and not getting the cath lab very frequently if you were particularly older, African-American, and female. So ultimately, we need to recognize not just the cardiovascular space, which is shown here, but these kinds of solutions are things that we could do throughout the Department of Medicine, getting the education out in the community to recognize their diseases. A really good one was put out by the American Heart Association in terms of face, arm, smile, getting people to recognize the symptoms of a stroke. And we need to do everything that we can to lower the amount of financial toxicity of our healthcare system. And that really means, that translates into prevention. We need to do much more in the way of implicit bias training. Everyone, particularly those who are in the position of selecting candidates for everything from medical school to internship and residency and fellowship, ought to have implicit bias training. And that's something that we can think about mandating for our department. Doing everything we can to address knowledge gaps and establish trust with our patients. And U of L, I'm not sure everybody has heard, but we're doing everything that we can at every level, particularly this incoming class of freshman medical students. It's actually going to be 39% underrepresented minorities and 69% female. And so we're doing what we can to create a more diverse health workforce, but we need further help. We need to continue the kinds of programs that are done at Central High School to try to get people into medicine, because we are still underrepresented around, even if we're doing well as a medical school class, but we need to keep, that has to persist and it has to be done with success. So since I talked with you last about this, there's been some more data that is really kind of confirming the need to work really hard on this. Everyone can pick out where Kentucky is, but what it's really saying is that as a nation, we are struggling, particularly with very high rates of cardiovascular disease and mortality. It does go by state, it does go by race, it goes by gender, and the lower left corner is the one that's very, very concerning, that we have high mortality rates in our population, particularly right south of us in Tennessee, and going up north to Michigan, driven largely by Detroit and Saginaw and Flint, Michigan. But these are the consequences of everything that we've been talking about this morning, and we have an opportunity to try and make this better. If we don't, this is what's going to happen. This was an estimate, a projection, and I just want to emphasize that word over and over again. These are projections of what's going to happen in the United States. And I love their central illustrations. This time it was just a little too much on the slide, so I turned it into something that's more digestible. And that is that if we don't do something programmatically to change the way our United States population is behaving in terms of lifestyle particularly, we're going to end up with so much more diabetes, hypertension, high cholesterol, and obesity that we result in ischemic heart disease. That's including the heart attacks, the heart failure, stroke, and the projections are that all of those will decrease in the white population and increase in racial minorities. The curves look very daunting to see these differences over time in the slope of the diseases, but it doesn't have to happen. We don't have to have all of these consequences from all of that risk. If we do public health efforts now to try to prevent this from happening, remove the barrier. And so, yes, this is where, as Dr. Kalra mentioned, I talk about nutrition. The fact that I'm looking at my watch and I went 32 minutes without mentioning nutrition very much is unusual. But what's happened since I saw you last is several things. One of them is that we've had more government interest in this. And we are redoing the dietary guidelines for Americans, and hopefully that document, the draft document, will be out shortly that we can then try to rectify, because it's always a problem of commercial interest influencing those guidelines. It's difficult to avoid in our society, but it's something that we have to take on and try to get the guidelines to adhere to science. So the nutrition differences that we're seeing are exactly what you'd expect, that every trial has shown that the African-American population that we have on the West End, particularly US-born Blacks, have a particular problem with nutrition in terms of how much healthy food they're eating. It's resulting in a lot more obesity in our community. And I'm pretty sure you've seen these slides before that, yes, we have some states, including Kentucky, with a lot of obesity, greater than 35% being dark, that it's a little less, except in Kentucky and the white population, that if you look at the Hispanic population, there are many more states, but if you look at the African-American population, it's pretty much everywhere if they have African-Americans. And so it has to do with our eating habits, as was pointing out by the Regards trial, showing the Southern eating habit, which is basically soul food, and in anything with high fat and a lot of animal products, a lot of sugar-sweetened beverages, and a lot of sodium ends up with all of the heart disease, kidney disease, and stroke. And so it's very true that every time we look at it, it's a huge opportunity to try to change these kinds of factors that result in the substantial amount of excess mortality. This data showing that if you would just change the lifestyle, you could account for at least 51% of the excess in African-American men. We put out there, and I hope everyone has seen this data that we put out there, that a lot of it has to do with television. I'm going over that again for a reason that I'll show you in a little bit. We published this last year that our television commercials are hurting our population, particularly fast food advertisements, because they show basically negative things. That is, animal products, refined grains on the hamburger bun, and then a sugar sweetened beverage and French fries, and you put all that out there and you change the way people behave, and that really is an opportunity because the regulators or legislators could actually curtail this. And it's been done in other places, including Canada and the European Union. And why do it? It's because our poor population is watching more television. People who are wealthy don't spend as much time in front of a television set, are not as influenced by all of this. We struggle with our tax dollars, and I'm mentioning this is a little older data, but it's still happening. And it's worth talking about now because we're hoping to change it. That is, our Congress actually spends a lot of money helping the industry, the food industry, produce things that are then unhealthy. And so, such as corn syrup and high fructose corn syrup. And so that contributes, in my mind, to our health, our food deserts. Because I like to say that that the word is misspelled. They're actually food desserts, and that 14 different compounds that are subsidized by our government or go into that particular product that I won't name in the bottom right corner. And that if you train people to desire unhealthy foods and they're not thinking about the health consequences, our stores have to carry them because that's how they stay in business. So we've been hoping against hope, really, that our 2019 prevention guidelines, with all of the things that we talked about, emphasizing diet and control of blood sugar, blood pressure, high cholesterol, smoking cessation, and judicious use of antiplatelet therapy, would actually make a difference. We put out there, fresh fruits and vegetables, nuts, beans, whole grains. That kind of diet will actually improve outcomes. And the question is, how well have we done? Well, we've proven that you can take a poor Black American population and make them better with a dietary intervention. It was done 10 years ago, that you could drop the rates of these risk factors that we've been talking about by changing the diet. And we did it on the south side of Chicago. And I'm mentioning that one again because we're embarking on a trial that's similar to this, but a little bit more extensive here, and mostly focused at Canaan Baptist Church, but really going all over. What we're hoping to do is to reproduce what we did before, but make it a larger study. And we've got a lot of criticism for intervening 5 weeks of delivered food. Great. Changed all the risk factors, great, but you didn't randomize it. Well, I'm not sure why we would have to randomize it, but we listened to the criticism, and we are doing a randomized trial this time. And we'll find out whether or not we can make this kind of difference. Large drop in TMAO. I know we talked about some of that last time. If you haven't seen it, please write that one down and study it. But TMAO from Cleveland Clinic needs to come with a warning. When you Google it, you'll end up a vegetarian afterwards, reading about it. We've shown that we can make a change. But the question is, can we make a difference? That is, 5 weeks of improved risk factors may not be all we need. How about making changes for a lifetime? We were able to use the risk calculator based on the changes that you just saw on the previous slide and decrease 19% out of that 21% increase that we have in adults with diet. And we didn't even do, the rest of the lifestyle stuff, just diet. We have a cookbook out there. For those of you who haven't seen it, please, jot this down. We can actually make a difference. So the wise man once said the best way to predict the future is to create it. That actually was Abraham Lincoln, and everyone talks about the Emancipation Proclamation, and people will argue back and forth about why he actually did that and the economic differences between the North and the South. But the fact is, he actually did it. And then we talk about Juneteenth, and we will be where Blacks, and particularly in Texas, were not aware of what had happened because there was no internet or anything to let everybody know. Well, it's still going on. That's the issue, is if we're still eating the food that we did back when we were enslaved and still having the shortened life expectancy, then slavery really isn't over. We can end it, but we have to do some interventions. So we went from one Republican president who did a lot to another Republican president that did a lot. That is hard. People do not remember kind things about Richard Nixon. But there's one thing for us vegan cardiologists that he actually did, and that he got people interested, as you can see at the top, in food, nutrition, and health. And he put on a conference. There was an 1,800-page report that came out, and it set the tone for now that we're in this struggle that I showed you with increasing cardiovascular disease and at younger ages. And I'm not sure you've ever seen those plots that take your population and show you what's happening to them in terms of males, females, age, mortality. What's happening is we're being squeezed in the middle. That is, our older population is getting older and our life expectancy is going down because we're losing people in the middle. And until so many of us thought that this was the opioid crisis, and sure, that's adding to it, but a lot of it is premature coronary heart disease. And this is something that is completely due to our lifestyle and our culture that we should be able to fix. So in September, we actually had the second, I guess it was 52 years later, food, nutrition, hunger conference with the White House. And President Biden got a lot of input from a lot of places, including myself. And I can tell you that the the 6 things that I was trying to get them to do, they actually talk about doing 5 of them, and they got hundreds of recommendations. There are about 200 different things that they're going to try to do. But getting rid of those congressional subsidies for unhealthy foods like high fructose corn syrup and refined grains, making sure that people are not doing the unhealthy non-vegan foods like animal products, making sure that you're not spending those subsidies on unhealthy things and that cost us more in the long term. And we'll use those congressional subsidies for healthier foods. That is, our problem is until we change our education system and get people to buy fresh fruits and vegetables, they rot on the shelf and the store owners won't buy them. And you end up with this food deserts or food deserts. And but that would be mitigated if we were to actually have them be less expensive because of the congressional subsidies that are now being, I would say, wasted on unhealthy foods. But we also need to complement that with the education programs that in terms of plant-based nutrition, evidence-based nutrition, and eliminating those food deserts. But one of the major initiatives there would be the red, yellow, and green labels. Now, that sounds like it would be something that the bacon producers would get really upset at, because processed meat is World Health Organization Class 1 carcinogen. People are still eating it. They're feeding it to us in conferences. And we really should have a red label on it so that people know that these are the kinds of things that we should not eat in large amounts. Yellow, maybe not so much, but please buy more things that are green. That actually has been done. It was done in Austria, done in France, done in Australia. It actually does work. It changes consumer behavior. The one that, and it was really great to make all these recommendations and to hear Joe Biden actually say them out loud. The one he did not go for that I had recommended was the advertising. And I guess that's a little bit too much into big business right now, but we're going to keep pushing for it. They did it with cigarettes. They've done it in other countries in terms of programming for children, making sure that they're showing only healthy food. We could do this. It's just going to take a lot more political capital and hard work to make that happen. So I was hoping to talk for 45 minutes. I guess I'm about 15 seconds short of that. And before opening it up, I would just emphasize that, and it's really not just cardiovascular disease. There are so many diseases that are related to our socioeconomic situation, but poor nutrition is the cornerstone of many of the chronic diseases. 80% of our healthcare dollars are actually spent on chronic diseases that could be improved with lifestyle, particularly plant-based nutrition, reducing risk and the subsequent diseases. But the bottom line is that we have to try to intervene as individuals, as divisions, as a department, and as a university. Try to help with the structural and cultural barriers to improvement, and being advocates, as I mentioned when I took this job, that it's not just about being the triple threat, teacher, researcher, and clinician, master clinician, but we also have to be good administrators and we have to be good advocates. And that means going to the regulators and legislators and try to make a difference for the kinds of things that our people need. If we don't do this, we will continue to suffer. So I want to announce that there's a couple of trials that are going through the IRB right now, but they actually are grant funded that I want to make sure that everybody knows about. The Heart of Louisville is our screening program, and the idea is to do CT for lung cancer screening, which will allow us to do coronary calcium scoring, or do the coronary calcium scoring if a person isn't a smoker. And we've been to Joe's Palm Room on the West End, the Lutheran Church, been to Canaan Baptist Church. We're going all over Louisville, and the funded part is 200 volunteers who are actually coming to find out if they have heart disease risk, and we're happy to do that. But we're also going to try and take the CT scan results and get them in for therapy. And it's going to affect a lot of the different areas of our healthcare system. We're hoping that everyone will be saved from coronary disease, and saved, of course, is statin, antiplatelet therapy, the plant-based diet, vegetarian diet, exercise, and de-stressing. We know much more about that than we did years ago. And we will continue to try and enroll people into that one. And that study will actually feed our disparity trial, which is the randomized trial between Mediterranean and vegan diet for people with known coronary disease. So if you know someone who's interested in changing their nutrition and they have coronary artery disease, they're welcome to, once we get rolling, get all the approvals and everything going. We will actually do their risk factors at baseline at 4 weeks after the randomization to Mediterranean or plant-based diet. And then for the next 4 weeks, they will cross over. So the vegans become Mediterranean become vegan. And then we measure the urine, stool, and blood markers and to measure their risk. But this time we were hoping not just to make a change, but to make a difference, which means that we're actually going to do patient education on fitness and shopping and cooking. Most of you have heard of Dare to Care that feeds a lot of people in the West End. Turns out they're right across the street from my clinic at Parkland. And so we're actually going to do cooking classes over there and try to get people to understand what good nutrition is. And we will actually have our staff calling and just come alongside the patient and who's willing to make some changes and try to help them with their lifestyle. So at this point, I'm going to put back up the 8 social determinants of health and open it up. I've gotten out my notepad. You're seeing the 2 things that I think are important, screening and intervention, but there's got to be a lot more that we can do. And I'd love to hear the thoughts of everyone. Any of these 8 areas or anything else that you can think of. I would love to hear where you think our department can be helpful to the issues that we've been talking about.
All right, I think Thank you, Dr. Williams, so much. Dr. Cave had a hand raised, and anyone, please feel free to jump in and with your comments and ideas and such. Go ahead, Dr. Cave.
Hey, Kim, can you hear me okay?
Perfect, Matt.
Great. I'm at Jewish rounding with the team, so we're listening on round. So this was an absolutely fantastic talk. There's a 9th box that you need to add to your last slide, and I would add it at the #1 position because it's the one that's on the news every single night, and that's environmental justice. So every night there's a train blowing up and derailing, there's a chemical plant that's on fire, there's a flood, there's a tornado, there's a forest fire, and they're happening in poor communities, generally minority communities, and they're leading to differential exposures to pollution in those communities that can impact health. And so in the last 1 to 2 weeks, the White House, I believe, opened up a new office to address this, Office of Environmental Justice. And, you know, we have a faculty member, Natasha DeJardinette, that's probably working on this. But we're in a unique position at UofL to address these problems. So in your own specialty in cardiovascular disease, you know, we've got the Environment Institute and arguably the world's leader in environmental cardiology with Dr. Bhatnagar. And I'm trying to do the same thing for liver. But this is going to be on the new NIEHS, which is the environmental health branch of the NIH. The environmental justice is going to be on their new strategic plan. We've got 2 major environmental health centers, as you know, at the university with the P42 Superfund and the P30 CIEHS, you know, that could work, you know, with you potentially on these things. But I think this has got to be something to consider. And so, for example, in my own specialty of liver, there was what I think could become a very important paper just came out from Mount Sinai that showed African Americans had the worst or most prevalent liver fibrosis, advanced liver fibrosis, which was kind of a surprise to a lot of people. And more surprisingly, it wasn't explained by obesity, it wasn't explained by diabetes, it wasn't even explained by alcohol consumption, but it looked like it was explained by potentially by poverty and differential pollutant exposures to metals and polychlorinated biphenyls. And you know, you mentioned TMAO, so these same polychlorinated biphenyls are shown to regulate TMAO levels by regulating the you know, enzymes that produce TMAO in the liver. But don't need to go into to all the trees, but I want to make sure that we clearly see the forest here. You know, that when we're turning on the news and we see a natural disaster every night, that's environmental justice, and that's disproportionately impacting communities of color and poor communities. Eastern Kentucky communities with the flood, you know, you mentioned Eastern Kentucky, and coal mining, metals, solvents that clean the mining communities, and the west end of Louisville, all the chemical plants, you know, in our, you know, 50-year history or whatever, 70-year history of chemical exposures on the west end related to Rubber Town, which our Superfund's addressing. So happy to work with you on that, and I'm sure Rooney, if he's on, may have something to add as well.
Would love to hear it. Just have to say out loud that I feel blessed as a department chair to have a division of environmental medicine to try to deal with these issues. It's also a robust source of research and really going to change the way things are done. And really appreciate all the initiatives, whether it's trees or barriers, and trying to improve all of that. Really stunned to hear about the fibrosis. Stunned to hear that it's not related to fatty liver as a consequence, and that means that we have a lot of work to do. So I appreciate your efforts, and anything that we can do to try to spread the word about this, about liver health and programmatic development to try to prevent some of it. That would be great. Looks like
Thank you,
Dr. Joplin. Thanks, Matt. I think Dr. Joplin has her hand up.
Oh, hi, Dr. Williams. just wanted to piggyback off of some of the things that Dr. Cave was saying. I think that, I see a lot of people in my clinic that, they're walking around with stents in their heart and they're okay with that. But the minute they find out they have something going on with their liver, they sit up and take notice because they're afraid. I think that screening for steatosis and NASH could be something that's feasible in some of these trials with FibroScan. I mean, we know that NAFLD is, folks don't die of liver disease; they die of cardiovascular disease when they have that. So, I mean, I would love to be part of your trial and some of the efforts if we could bring FibroScan to the community. I've been involved with screening on a community basis at health fairs. And I think that it can improve outcomes on a community level, especially getting folks into clinic who have advanced liver disease. I know we can change their outcomes. As for some of the areas that are termed food deserts, a lot of the foods that are available are highly processed with a long shelf life, and some of those preservatives have metabolic effects. And it would be wonderful to look at actual chemicals that individuals are eating and find out if they actually have health impacts on humans. I've done some mouse studies showing that when certain preservatives are added within the FDA limit, that they cause profound metabolic disarray.
Wow.
So thank you so much for your talk. It was wonderful.
Well, thanks. So on the latter issue, hopefully those studies will get in front of the FDA. I just got appointed to an FDA panel. So send me the data to me. I'll send it to them. I'm happy to try to promulgate that data. On the first part, if we could, I'm thinking that you and the FibroScan, we could actually partner with our nurse coordinator, Rose, who will be, I know we're doing Canaan Baptist Church, and then we're doing Juneteenth and Kentucky State Fair. I got a handful of them, but we're going to be basically doing a screening program pretty much everywhere, once or twice a week. So we're welcome to try to figure out how to partner. We'll why don't we go offline later and talk about some of the practicalities.
Wonderful.
Sure.
Thank you. Great.
So I see Dr. Kalra and Dr. McLean. So I think Dr. McLean is first on the left side. Okay. Hi, Dr. McLean. Good morning.
So great talk, and kind of expanding on what Matt was saying. I've spent much of my life for the last couple of weeks reviewing large center grants, and social determinants of health is in all of them. And we have a couple of unique things here. So in our School of Public Health, Dr. Kong has access to the Medicaid database for everybody in Kentucky. So that's a unique tool. The really hot thing is a thing called geospatial health. And so it's your geologists that have everything mapped. And so we need to go to our main campus and talk to our geologists. I think we actually have people there that are interested. And then with the Envirome Institute and Ted Smith, the wastewater. So these are all unique things to be able to map people. And so we can get all them together to work with you.
Well, that would be spectacular because we're certainly going to be there. It would be wonderful to actually have the data that we can present about what needs to change. And, wastewater, gosh, hopefully it's not filtering back into what people are consuming, and it's more of a diagnostic test.
Right.
Exactly. And people have learned with COVID how important wastewater is for knowing what's going on in a population. Would love to work with people, find out what's in it, and see how to impact it. I know we can't, you can't stop all of the redlining that happened west of 9th Street decades ago, but we can start to mitigate some of the downstream effects. So thanks for that, and look forward to trying to set up meetings and do that. Dr. Kalra?
Yeah, thank you, Dr. Williams. This is really important information. I think all of us need to hear this and hear it repeatedly. So, especially in the cardiovascular space, like you pointed out, there's so much avoidable morbidity and mortality that we can take care of. And congratulations to you, really, for actually doing a lot of the work on the ground to effect change. A lot of people talk about this, but you're actually one of those people who goes to ACC and the White House and makes change happen at the grassroots level. I can tell the audience here that you screen how many thousands of people at these sports venues and in churches and in barbershops to pick up people with hypertension, metabolic disorders. The comment I have is, it's directly related to your trials is calcium scoring in these individuals. And this is preaching to the choir here. The latest guidelines recognized, the cholesterol guidelines recognized South Asian ethnicity as having higher risk. And I would love for your trials, we're collaborating with you in this regard, to be able to show that African-American race is also a risk enhancer, and maybe we need to democratize and just lower the bar for calcium, coronary calcium artery assessment in these individuals, so that we not only take care of primordial prevention with diet, exercise, etc., but we have the resources. I know you're working on that to get more of these folks to have free coronary calcium scans, so we can institute preventive therapy early on to avoid ischemic heart disease, heart failure developing down the road. So we're really excited that you brought these trials here, and we want to encourage people to refer patients for those trials.
Well, thank you, Dr. Kalra. So, Dinesh, as you know, we are nervous about the major tool being the risk calculator that I showed. Are you 5 to 7.5 or you're 7.5 to 20? Because it doesn't call out other at-risk populations. Hispanic people have more disease than whites and live longer, the Hispanic paradox. The South Asians have premature coronary artery disease, and some of it's lifestyle and some of it is genetic, I'm sure. And so we recognize the deficiencies in our risk calculator, but more than just ethnicity. We now understand the whole idea of lifetime LDL exposure, and we really should have this going down to age 30. So ACC and AHA are talking about it, and Don Lloyd-Jones was one of the people who have been putting all this data together. We need bigger data. We need bigger trials for the pool, because it does come from trial evidence, the pool cohort. Without that, you're right. We probably should be doing some extrapolations, take our high-risk patients and say, why, Williams, are you starting at 40 when you should be starting at 30? It's going to take a little bit more consideration, but I agree with you. That's probably the direction we should be going.
Yeah, thank you.
And Dr. Williams, I know we're kind of up against it, but if people can hang on for just a few more minutes, because there are some questions in the chat area.
Sure.
First one, real quick, Dr. Stephen Jones want to know, was physical activity on the list?
So definitely physical activity is important. You can't exercise your way out of a bad diet, but we definitely in our trials are going to be coaching on physical activity. Our target for primary prevention, people don't have diseases, is 150 minutes a week, and that's one of the cornerstones of our 2019 prevention guideline. But I'm always aiming at someone for secondary prevention, or when you have known disease, to be at 300 minutes a week. And but it's a moving target, no pun intended, where it turns out that plaque regression, which is what we're measuring in the disparity trial, will actually be related to how much high intensity exercise a person does, as well as nutrition. So absolutely, it's important to keep that on the radar screen. And I'm hoping that everyone in the department, their H&Ps include a note on the diet and a note on the physical exercise, and try to do the counseling. I know it takes an extra few seconds to counsel people on both.
All right, real quick. Don Castor in nephrology says, as a nephrologist, I try to educate my patients about the benefits of eating a more plant-based diet, but find my time in clinic is often limited. An increase in nutrition resources / dietitians will be so helpful. Are there any plans to increase these resources for patients in the outpatient clinics?
I'm writing that down. So I was always preaching that the way to get this to happen for your patients in a clinic is the 3 T's. You spend your time, you have tools, and you have a team. The tool that I like, of course, is the Association of Black Cardiologists, vegan cookbook, but there's another one from the mayor of New York that is really good. Mayor Eric Adams, African-American cop who became a politician, had all kinds of diabetes and all this stuff. And I had never heard of someone's diabetic retinopathy going away because they turned vegan. I'm always afraid of anecdotes instead of randomized trials. But anyway, and I did write the foreword to his book. That's a disclaimer. But he spends a little bit of the book talking about his story, and the rest of it is actually plant-based recipes so that the African-American community can, and anyone can relate to. So please use the tools. But you're right about the team. We need to focus more on plant-based nutrition. It isn't just physicians and cardiologists who are lacking in this area. It's actually dietitians as well and nutritionists. And so we need to get them the latest evidence and get them to change off of, food pyramids and that sort of thing. There is some good leadership happening at the American Dietitian Association. They actually are saying plant-based nutrition is the way to reduce chronic disease, and hopefully that message is going to be heard. But I agree with you. We should be focusing on making sure that we have evidence-based dietitians in our clinics.
All right, and I guess kind of the last one, this is going to be a 2-parter, and the first part is from Dr. Emmons in bone marrow transplant. He wanted to know, and this kind of ties into Dr. Castor's question, said, could we produce a UofL pamphlet website and YouTube dealing with these issues, which is continually updated with the latest recommendations to give automatically to every patient visiting UofL clinics? And then the second part of his question is says the web of all these interactions, liver fibrosis, coronary disease, neurodegenerative disease, and others have their underpinnings in chronic inflammation. Is your study looking at markers of this and other impacts by shifts in microbiome?
We definitely are. So I didn't spend much time talking about those risk factors, but you may have seen the recent Lancet article by my good buddy, Paul Ritker. I was fortunate to be the discussant on it, where he took prominent, strength, and reduce it, 3 trials of statin therapy, and showed that you get your LDL down to less than 70 and still have a really bad outcome if you had residual inflammation. It's important because what are we really trying to reduce? TMAO, LDL cholesterol, and high sensitivity C-reactive protein, 3 markers of bad things that are going to happen. And it turns out that when you're doing a Mediterranean diet or a keto diet, the only diet that lowers all 3 is a whole food plant-based diet. Not junk food vegan, it doesn't, because that'll raise your LDL triglycerides. But if you do the diet well, you will have dramatic falls in all 3 of those risk factors. And so, yes, we are measuring all 3 before and after. So thank you for that. And absolutely right. So Jason, that's in your area. That we just so everybody knows, Jason has negotiated with View Medi so that all of our grand rounds are not just going to be stored there, but actually they'll be sending out our UofL grand rounds so that everyone can see what we're doing. But we also have the Cardinal Minute, and you're absolutely right, Dr. Emmons, we need to keep going with that.
And okay, and to wrap up, Scott Hannon, I don't know if he's going to post it. Scott in infectious diseases I guess he'll have the last question or last comment.
Yeah, thank you. I just wanted to thank Dr. Williams for another excellent talk, and to commend you, sir, for bringing up the Farm Bill, because we spend a lot of time in our political discourse talking about the unsustainability of the funding for Medicare and Medicaid, but not nearly enough time talking about the Farm Bill, because it only comes up for debate and reauthorization every 5 years. But we spend several $billion per year subsidizing the cheap calories that we get with rice, corn, wheat, and soy. And we make a lot of empty calorie food products. And that's the basis of the standard American diet. And it's contributed to an epidemic of chronic disease. And if we don't start spending our money more wisely on the farm bill, I fear that Medicare and Medicaid may well become unsustainable. We got to put money into the right things to begin with, and maybe we'll end up saving some money on the back end with all of our medical expenses. And thank you for bringing that up.
Well, thank you so much. And I was, really excited to hear Joe Biden talk about this issue that we had brought up. The question is, he's got a little bit of time, and I think he announced that he's running for president again. And I just can imagine, maybe this is a little, healthcare, public health paranoia on my part, that all of the goodwill and all of the news and everything that we were aiming for may not turn into actual policy and plans. And so I'm hoping that that everything that you're talking about, the change, particularly in the congressional subsidies, isn't just pie in the sky, but it actually will be actuated. So, but we have that's on us, isn't it? That is, I know you're talking about being active with advocacy, and this is something that we all need to do to let them know that it's not acceptable to have our country bankrupted and not have education for the poor and not have military readiness because we can't afford it, and our young people are overweight and obese and dysfunctional. These are things that we can fix with lifestyle and get our congressional subsidies pointing more toward health than disease.
All right, and I think that kind of wraps it up today. Do you have any closing or wrap up comment, Dr. Williams?
I'm just going to say thank you to, and that the conversation continues. Yeah, everyone knows my email address. Please send me more thoughts or something will hit you in the middle of the night. Jot it down, and please, more ideas. This was a great session, and hopefully all of the faculty members who spoke up about different aspects of the things that we can do for health equity, we can try to turn them into programs. So please, let's keep it going. I really appreciate everyone's input and your interest.